I'm going to continue this journey and take you to the other side of the cardiac care to more chronic heart failure. Okay. And go through the guidelines that has been established and some of the newer one that's just been published to take you through how we treat heart failure, both outpatient and in some instances inpatient. So this is a new expanded definition of heart failure. Heart failure is defined as complex clinical syndrome that results from any structural or functional impairment of ventricular filling or rejection of blood. And you can see that the classification is now divided into 4 separate categories, from heart failure with reduced ejection fraction of less than equal to 40%, those with HFpEF or preserved ejection fraction, and further defining the HFpEF borderline, those with 41 to 49%, and these are the individual who has been there and despite all the medical therapy sort of lived there, and versus those who have improved, those who had ejection fraction of 20%, but now have greater than 40%. And so those are called HFpEF improved. And the idea is, it is thought that this the last category of patients actually has a different trajectory and outcome, and to identify them so we can learn more about them. But that is the linguistics that you will see in the literature. To go through the pathophysiology of heart failure will take a lecture in itself, but these hit the highlights. It happens with any kind of myocardial injury, myocardial infarction, hypertension, and what have you, and anything that reduces the left ventricular performance and decreases the cardiac output. And this sets in the motion of the neurohormonal responses, and of course, this is where we intervene, where we attenuate or we block some of these responses so that we can avoid or reduce the vasoconstriction and the water retention and all the other harmful effects that we see from these constant neurohormonal responses. The staging of the ACC-HA heart failure staging, this has been published now for over a decade, and as you can see, stage A are those with high-risk features: hypertension, diabetes, obesity, smoking, just to name a few. And these patients really, this is the prime time where so much good can be done by identifying and helping the patients to reduce their risk. And then stage B is those who have developed structural heart disease, but they have no symptoms. And this could be LVH, this could be some sort of a valvular disease, and even a mild LV dysfunction. But again, they are totally asymptomatic. Stage C is usually when they come to, these patients come to a physician's attention, where they begin to get symptoms along with the structural heart disease. And of course, us in our team, majority of our patients, we see them at stage D. And this is where they have refractory symptoms, multiple hospitalizations, and where we are mandated, due to the severity of their illness, to go to the next level, which is looking for any kind of a device or organ transplantation so that we can help them prolong their life and their quality of life. But you could see the 1-year mortality listed there at the left, from low as 2 to 3% a year at stage A to high as greater than 50% at stage D. And it is true that end-stage heart failure kills as much or even greater rate than any kind of cancer. And we see this every day in our cohort, and actually in some individuals who are not that old. And actually, as I advance on years, I don't think 40, 50, 60s are that old. But we deal with death and mortality in these young individuals all the time. Now, this is to differentiate from neurocardiovascular class. You use this all the time, from functional class 1, 2, 3, and 4. And to just highlight the fact that the two are meant to be used in concert. One does not complement the other. And the stages progress in one direction, of course, while the functional class can go back and forth depending on the treatment and depending on the compliance and their state of disease overall. Now, the stage A, to go through them, these are the high-risk patients without any structural heart disease and no symptoms. And you can see that this is where it is really strongly advocated for any kind of risk factors, hypertension, lipid disorders, any kind of habits that can be modified to reduce their risk as they live on. It's very, very highly recommended. Stage B, this is where you have identified any kind of high blood pressure, any kind of lipid disorder, to use those ACE inhibitors and the beta blockers and the statins, because this is where you could do the most good. Yes, there is some structural heart disease, but these therapies really do work well, and they can really help your patients to live better lives, to mitigate from any further cardiac harm. Now, just to get some of the major treatments that we use in heart failure, you're all familiar with the SOLVE and prevention and the treatment trials. You know, I remember when SOLVE treatment trial first came out back in 1991, and not to date myself, I remember the excitement and just the amazement of my whole medicine team, because up to that point, we only had diuretics and digitalis, and there really wasn't anything that we can do to modify or decrease the mortality that we saw all the time in heart failure. So this was big, to have a 16% decrease in all-cause mortality from a medical therapy. I mean, this was a huge news. And of course, SOLVE prevention showed us that even in asymptomatic individuals, if they have reduced LV function, that this should be used. And then there were a lot of studies to show that, you know, should we push it to the limit and dosing, you know, how much is too much? This has gone through the years in the past few decades, but low dose is beneficial, some is better than none, and whatever your patient can tolerate, really get it on board and monitoring them very carefully. So this is the stage C ACE inhibitors and ARB recommendation, and as you can see, the A recommendation comes from, you know, use them to avoid using ACE and ARB in face of spironolactone, because you can run into hyperkalemia and kidney injury, so that you should avoid. But otherwise, please do make sure that judiciously ACE inhibitors come first. If somebody's ACE intolerant, then you go to the ARB. Beta blockers has been the key turning stone in our heart failure, fighting with heart failure. And again, I remember the days when there was such amazing literature of arguments and debates. Why would you give this patient with EF of 20% that further reduces cardiac output? I mean, are you out of your mind? I mean, I know right now this sounds like, you know, did you really have that discussion? The answer is yes. I mean, we really had really robust discussion because at the time, it was all hemodynamically driven. We were after increasing cardiac output, and this is not the drug to do that. But long term, as we now know, beta blockers are amazing therapy, and probably the one that we push the most. And this is something that we have known that saves lives. It's also good for those with arrhythmia. And you can see all the trials that has been done, and over 6,000, I mean many thousand if you put them a cumulative number. But it has shown time and time again how effective it is. So it is recommended as grade A, and you can see you can use one of the three beta blockers, bisoprolol, carvedilol, and sustained release of metoprolol. And I again emphasize the sustained release, which is Topro XL, not the tartrate, but the succinate. And this is a mistake that we still see commonly happening, not the twice a day beta blocker, but the once a day, and that's really important. And this is recommended to all patients. And again, the matter of dosing comes up, and this is even more important in beta blockers as it is in ACE inhibitors, that a little is better than none. Even if you can start somebody on 3.1 to 5 carvedilol and send them home, studies have shown that it's really effective and beneficial in helping them to preserve their cardiac function and give them a chance to for the cardiac recovery. There are some differences between the two beta blockers from the dosing, carvedilol twice a day, metoprolol, succinate once a day. There's more of a antihypertensive or hypotension producing effect with carvedilol. So if you have somebody with high blood pressure and reduced ejection fraction, carvedilol is your drug. If you have somebody with very soft blood pressure, you probably want to go with metoprolol. There's some other specific population with those with diabetic. It has less insulin resistance, and for those with new onset diabetes. And for metoprolol with COPDers, it's more selective and less potential for bronchospasm, so that might be a better drug for that class. Rouse demonstrated to us one of the older drugs, spironolactone, how it can really help to preserve and actually has beneficial in reducing overall morbidity, mortality, and heart failure. Over 1,600 patients, functional class 3, and 30% in functional class 4. Actually, this had really one of the sickest cohort in the modern era of any large clinical trials. Only 10% of beta blockers, mind you. This is an old study, and at that time, beta blockers were not pushed as heavily. You can see the exclusion with watching the creatinine and potassium, and they started at 25 milligrams a day. They got labs at 1 week and 4 weeks, and and I still use this practice, especially among the elderly and with those with diabetes and any kind of CKD. I really do make sure that they go for labs at 1 week and 1 month. There was a series of hyperkalemia and renal failure when spironolactone was first used with RAL. So I think this is a lesson that we can all take back. And so this is, again, recommended for those with functional class 2 to 4. Again, watching the creatinine and monitoring them very vigilantly. But most patients, and we even start them at 12.5, half a tablet a day, and make sure that you follow their labs. But they tolerate this very well. If they have any kind of CKD stage 2 or beyond, again, on an elderly population, you need to watch them very closely. So what about the hydralazine isodil? The AHAP trial demonstrated that on top of, not replacing, but on top of the ACE and ARB, beta blockers, and spironolactone, utilizing hydralazine isodil combination on the African American cohort has significantly improved outcome. Now, having said this, it is not the easiest thing to take 3 times a day. Bidil, is at the cost. There's a cost prohibitive aspect. So this is often utilized those with CKD, where we are limited in how far we can push or use the ACE and ARB at all. So there is some real world versus what is recommended in guidelines. But if you do have a patient, African American individual, hypertension, LV has remodeled, EF is low, please remember this and give them the benefit of adding the hydralazine and isodil combination. And you can see the recommendation here, as well as the digoxin. It has a grade B recommendation. It has been shown to be beneficial, but again, you have to be very judicious in monitoring those with elderly, any kind of CKD, especially in women, because they can be prone to ditch toxicity. And they do mention the renal insufficiency being one of the main reasons why we use hydralazine. Anticoagulation does come with a grade A recommendation. Those with permanent or persistent paroxysmal atrial fibrillation, which is an additional risk factor for cardioembolic stroke. But if they don't have any defined risk factor that you need anticoagulation, having heart failure itself is not an indication to put them in a systemic anticoagulation, so it is not recommended. The drugs that are not recommended for heart failure include, again, utilizing the ACE, ARB, and aldosterone antagonists together, and hormonal therapies beyond what you need to correct deficiencies, not recommended, and calcium channel blockers, especially verapamil, those that can decrease cardiac output, and are not recommended, those with heart failure and reduced ejection fraction. So if you put it all together, in the past 2 decades or so, we have made a significant inroads in improving outcome in the heart failure population, initially with ACE inhibitors, adding beta blockers, and adding aldosterone antagonists on top of that, with a significant improvement in survival. And we were stalled there for actually quite about a decade or so, and now we now have addition of 2 new drugs that has been added to the guidelines, and it's really exciting time for that. And this was a joint recommendation between the ACCHA and the ESC that came out last year. And one, of course, is covering Entresto and we have music. Okay. And of course, you all know how this works. The endogenous vasoactive peptides, these are the ones that we're trying to increase in a patient heart failure population, and it decreases neurohormone activation, decreasing the vascular tone, fibrosis, and sodium retention. And of course, naproxen is one that degrades them, so if you can inhibit them, you can prolong their course of action. And this was studied in the landmark clinical trial Paradigm Heart Failure. And you can see the entry criteria there from functional class 2 to 4 heart failure. EF was initially less than 40%, but in the later 35%. You could see the elevated BNP. And any use of ACE or ARB, but able to tolerate a dose equivalent of at least enalapril 10 milligrams a day. I'm sorry, this is a little strange, but don't expect me to sing. You would not like that at all, trust me. And the guideline recommended use of beta blockers and aldosterone antagonists. And you can see the blood pressure also had a limited criteria there as well, entry criteria, because this agent can cause hypotension with systolic blood pressure greater than or equal to 95, GFR of greater than or equal to 30, and serum potassium that was less than or equal to 5.4. Oops. And you can see the cardiovascular overall morbidity and mortality decrease, a very significant improvement in overall outcome, and the number need to treat in order to see the benefit was 21. So this was a huge finding, and this is on top of all the therapies that we have that we know improve outcomes. So the fact that having this therapy on top of that added additional incremental value was an improvement, incredible finding. So this is a now class 1 indication in patients with chronic symptomatic heart failure with functional class 2 to 3 who tolerate an ACE or ARB replaced by an RNA is recommended to further reduce morbidity and mortality. You do need about 36 hours of washout time if you're going to take somebody from an ACE inhibitor to an RNA. If somebody's in an ARB, you could just replace one to the other. And of course, they should never be used with anybody with history of angioedema. Most frequent adverse events really is hypertension. And so they do come in 3 doses. It is recommended that you use on a lower dose first and monitor them carefully. But people do tolerate this well, and actually we have seen a significant improvement in clinical class and also LV function and using this class of drugs. So one more, and then I'll come to an end. So ivabradine, this is to control the heart rate, and this acts by reducing the heart rate via a specific inhibition of the Fani channel. This is present in the sinoatrial node, and the way this works, the mechanism is different from that of beta blockers and calcium channel blockers, and they do not alter the ventricular repolarization, myocardial contractility, or the blood pressure. And as you know, the SHIFT trial that was published demonstrated that there was a meaningful decrease in the composite endpoint of cardiovascular death and hospital admission. But it is noteworthy to mention that it's mainly driven by hospitalization and not mortality. And so it received a grade 2A recommendation for management of those with chronic heart failure. And I think the big take-home point here is that you really must push the beta blocker first. So make sure that the beta blocker is as much as the patient can tolerate it before you think about ivabradine. And I think that brings me to end, and thank you and good luck.